We are going to be having four panelists with us today. And the first panelist is going to be Dr. Ahmed Khalid. And he's a medical doctor, a health policy researcher, and a lecturer on health systems and policy. He completed his PhD in health policy at McMaster University with a focus on supporting the use of research evidence to inform decision-making in crisis zones. Previously, Firaz worked as a health policy researcher at the Research Unit of Humanitarian Stakes and Practices at Médecins Sans Frontières in Geneva, Switzerland. He also worked in the Department of Child and Maternal Health at the WHO, and he has expertise in medicine, education, health policy, knowledge translation, and health emergencies, working with relief and intergovernmental organizations. He has attended St. George's University School of Medicine in 2005, where he graduated MD with research distinction. He also holds a Master's of Management from McGill and both a Master's in Health Professional Education and Graduate Certificate in Population Health Risk Assessment and Management from the University of Ottawa. So it is my pleasure to ask Dr. Ahmed Khalid to start his presentation.
Hi, everybody. Thank you so much for that introduction. That was very beautifully said and very eloquent. So I really appreciate it. It sounds very pretentious, but I'm one of yours. I'm a fellow graduate at St. George's University, a proud alumni, and St. George's will always hold a very dear place in my heart. So it's a pleasure to join you all, and thank you for giving me the opportunity to speak on something that's been sort of the focus of my work for the past 8 months. So let me just give you a bit of introduction. So I'm actually right now in in Canada, in Toronto. So in Canada, COVID-19 has played out quite differently for us, and particularly around social issues and equity. So for us here in Canada, COVID-19 overall we've seen the biggest impact around long-term care homes, where we've had to shut down a lot of them because of the rapid transmission of COVID-19 and the lack of infrastructure to really address the health needs of people who are in long-term care centers. That's one. And two, we've seen a huge impact of COVID-19 when it came to our vulnerable population. So our inmates, our homeless population, our lower socioeconomic status individuals had been hit the biggest when it comes to COVID-19. To give a little bit of a recap to start this panel discussion, I think it's important to indicate the toll COVID-19 has had globally. With more than 46 million confirmed so far, more than 1 million deaths, I think it's fair to say that COVID-19 is going to create a massive system level challenges across the globe. Here in Canada, we look at it from 4 particular systems. We look at it from a political system and the impact it had on a health system, on a health research system, but also from a perspective of international humanitarian aid system. So when we look at it from a political system, I think now more than ever, what we're seeing is that COVID-19 is asking for better foreign arrangements between countries. And just to be more clear what I mean by that, I think what COVID-19 has showed us from a diplomatic political state is that no longer can public health and public health interventions be a sideline in the decision agendas of governments in trying to decide funding and interventions across the globe. We know, for example, here in Canada now, we're seeing the importance of foreign agreements and trade agreements being put in place when it comes to PPE supplies, but also in terms of securing vaccines and medication. And when it comes from a perspective of social equity, the big conversation we're having here in Canada right now is once vaccines are secured, and in Canada, we've been able, from a political perspective, to secure deals with some of the biggest pharmaceutical companies in the world around making sure that we have enough dosage of vaccines once they're available. But the real question becomes in terms of equity is who gets the vaccine first? Will it be our seniors or elderly and immunocompromised, or will we be trying to see a different way of administering vaccines that really tries to get to everybody in the population, not just the subset of the population? So my job here today is really to discuss some of those social equity issues that have arisen because of COVID-19 from different perspectives. And when we look at the health system, I indicated earlier in my presentation that long-term care centers have been sort of the biggest failures that we faced during COVID-19. What COVID-19 did, it really provided a magnifying glass to show us flaws in our system from a health perspective and where we could have improved or where we failed our sort of social vulnerable populations in making sure they have the best access to something like vaccines and treatments during COVID-19. So to be more clear here, what we saw happen in COVID-19 for us in Canada is our long-term care centers, because of the virtue of how they're structured with shared accommodation, part-time employees going from one long-term care center to another, it was a big disaster. And so it was the first impact we felt, which led the government to really cause a massive widespread shutdown of our long-term care centers, and the call for healthcare professionals, anybody who's been retired, anybody who used to serve in the medical and the health system, to really get back into the front lines to help support our long-term care centers. It got so bad that we actually had to invoke the military to help actually address our sort of long-term care centers. And the Canadian Red Cross now is playing a fundamental role, which is an NGO, first and foremost, a non-governmental agency, to support the government in figuring out how do we actually support COVID-19 pandemic response in places that we know are very vulnerable, which is our long-term care centers. Then when it comes to our international humanitarian aid system, for the first time ever, COVID-19 is allowing this collaborative relationship between the three other systems of the international humanitarian aid system. We're seeing this with refugees, another very important vulnerable population. Much of my work actually focused on looking into what has been the impact of COVID-19 in refugee camps. We knew early on, back in December, when the first case was identified, that it's only a matter of time till we see a case of COVID-19 in refugee camps. Refugee camps, in terms of the setting, present very similarly to what it presents very similar to what long-term care centers present, which is the idea of shared accommodations, very small accommodations, and little access to healthcare services. So we knew that that was going to be a big concern when it comes to the international humanitarian aid system and how it will play out for our refugee camps. Luckily, we haven't had a massive widespread outbreak yet in all the big camps like Rohingya refugee camp, Zaatari camp in Jordan. There have been some cases, but the ability of the international humanitarian aid system to collaborate with governments to really build up infrastructure has been very key in responding to this. And lastly, I really want to allow enough time for a discussion, so I'm keeping my presentation very short. When it comes to health research system, which is my bread and butter, I do a lot of health policy research. We've seen a tremendous spike in the number of evidence synthesis when it comes to COVID-19. Never have we seen this amount of research being generated in such a short time, that it actually led to what we call it now an infodemic. We have an infodemic when it comes to COVID-19 research. The surplus of synthesis of evidence across the globe has called for sort of a collaborative framework to help all of us work under one umbrella to figure together what is actually needed in terms of evidence, and are we addressing in our evidence synthesis the needs of vulnerable populations? Are we really trying to figure out who needs the evidence, in what time can we provide it for, and are we answering questions that serve our vulnerable populations? Thanks everybody for having me here today, and I look forward to the discussion.
Okay, thank you, Dr. Khalid, and it's a pleasure to listen to you, because health policy is my thing, and at times I struggle to find out somebody I can collaborate with. So look out, I'll be keeping in touch to get some ideas on our potential collaboration. All right. Would you have any questions for Ahmed before we move on to the next presentation?
What we can do actually is to have all the panelists just share their notes, and then we can contribute together with questions.
No problem. All right. Well, the second presentation is from Dr. Chris Ora. He's currently a professor of veterinary virology at School of Veterinary Medicine, UWI. He's a qualified veterinary surgeon, has a PhD in viral immunopathology, and has many years research experience working predominantly on vector-borne viral and protozoal diseases. Chris has worked in many countries around the world, including Mexico, Uganda, and Zimbabwe. He took up his post at UWI in Trinidad in early 2012 and is currently running a One Health-based research program. He is currently supervising 7 PhD and MPhil students and received the UWI Vice Chancellor's Award for Research in 2017. He's a member of the UWI COVID-19 Task Force. So I welcome Dr. Ora to his presentation. Welcome.
Hi everybody. Thank you very much, Dr. Roberts, and thank you, Satesh, and thank you to St. George's for enabling this great conference. So I'm going to follow on from Ahmed, talking a little bit about the intersections between COVID-19 pandemic and social justice and equity. And I'm going to really focus on my experience as a virologist, working on many animal and zoonotic diseases around the world, in many countries. And I'm going to look at how viruses really have an impact on social justice and equity, sort of my experience really. And whether it's animal viruses, human viruses, or zoonotic viruses, I think there are very good examples of exactly what Dr. Ahmed said. They're like a magnifying glass showing up the flaws in our society. And so moving swiftly on, I think this is an interesting statement, and it's very true. Viruses don't discriminate, and neither should we. And as a virologist, we know that when it comes to causing disease, severity of symptoms, there are virus factors that are taken into consideration, but critically, there are also host factors that affect viruses and how severe they are and what kind of symptoms they see. Or laws. And this is really being personified at the moment by COVID-19. And because host factors are really impacted by discrimination. And we're really seeing this now. And I wanted to open up a little bit at the start, just for a minute or so, and talk about a couple of other viruses which really emphasize this as well before I talk about COVID-19. And why do we keep on failing to control and prevent viral diseases? I mean, we see time after time, we've seen all these pandemics, an increase in pandemics, as we heard from one of the research talks today, over the past 20 years. But we don't learn our lessons. We haven't learned our lessons. We didn't learn our lessons from the first SARS outbreak. And if we had, we might have avoided this one. And we see many diseases as far away, out of sight, out of mind. And so we don't work on them. And this was really emphasized by the USA, that stopped working on African swine fever virus for decades. And now look where we are now. Of course, they've started working on it now, and we're close, or much closer, to finding a vaccine. And we don't support research at source where the viruses are circulating. And this is really key, that we need to work on these viruses at source. So we actually avoid them coming over to the Western countries, because we do something about them at source. And we have to ask ourselves difficult questions. Do we care if vulnerable populations in places like Africa are being affected? And I'll give you some examples about why we don't. And evidence for really structural racism that's going on, possibly, probably in many countries, when it comes to diseases that are circulating in Africa. And this is a pig pen in Uganda, which is empty. And the reason why this is empty is it was affected 3 times by African swine fever virus, and they couldn't afford to keep the pigs anymore. And we all know that backyard animals like sheep and goats and pigs, which are kept usually by women in villages across Africa and the world, that they are the meat for the money for sending kids to school. They're the money for they're the funding for getting food on the table. And if these diseases are allowed to spread, there's massive hardship going on in with these extremely vulnerable populations around the world. And we in the Western world don't do anything about it. We leave it there because it's out of sight, out of mind. The terrible example that I always, which really emphasizes the cracks in our society that we need to do something about, is the Ebola situation. I lived in Uganda for many years, and there were frequent outbreaks of Ebola virus where people were dying. And this Ebola virus itself is a fantastic candidate for finding a vaccine. It has very good immunogenic proteins, but nobody put the work in, because it was a virus that was affecting people in Africa and wasn't affecting the Western world. And when it came to West Africa and then came out into America and the UK, of course, people started working on it then. And within a couple of years, we now have a great vaccine. How does this reflect on our society and what we think about these countries where these viruses are circulating? SARS-CoV-2, we know from many respiratory viruses, we know that they're transmitted by direct contact. And we know that the main means of spread are from human to human transmission by droplet or close contact, although we know about asymptomatic infections, and we know about pre-symptomatic infections and transmission, and we know about limited airborne spread. So we know that people who are in direct contact are going to get are more likely to get the virus. We also know from a fact of host factors that I was talking about earlier, certain groups of people, and we've heard about this during the conference, are more susceptible to the severe effects of COVID-19. And we see here, right from the start of the outbreak, the older populations that were dying of COVID-19. We also know that people with underlying health conditions, these are the host factors, were predisposed to serious conditions. So we know this now, we know this, and we know how to how to stop this virus transmitting. It's avoiding these 3 C's: closed spaces, crowded places, and closed contact settings. But this, as Ahmed was saying, has really emphasized that there are people, vulnerable people, that have no choice but to enter these settings, and in some ways go right into the middle of this Venn diagram here. And this is a little example of here how Black and African people and Hispanics can't afford to work at home. So they have to go into work. So due to socio-economic and economic considerations, they can't afford not to work. They have to get onto crowded transport to get to work because they have no choice. They have to work in unsafe, unregulated workplaces in a lot of cases, where they're in close contact with people. These are the 3 C's. When they return home, the people at home are as often more people at home because of their home environment, and often old people at home, partly because those old people can't afford to be sent to care homes, or because their culture dictates that they look after old people better than people in the Western world and have them at home with them. These people also have no access to healthcare, and they're also more susceptible to the non-communicable diseases that we've heard about, like obesity and diabetes. So we're seeing these headlines around the world. 2.5 times higher, more deaths in Black and Asian Brits than white. Black people 4 times more likely to die of COVID-19. Why are more people from what we call Black and minority ethnic community backgrounds dying of COVID-19? It's the socio-economic factors. We see these kind of figures here, which I won't dwell on, but again, minority groups are far more likely to die of COVID-19 than white people. And this is shown here in this figure. Black and African Americans compared to white people in New York likely to die. And Black Americans are far more likely to know someone who has died from COVID-19, 31% more likely than white people. So, and this is occurring not only in America, I know America is getting bad press here, but also in the UK as well, where you see other ethnic groups and Black Caribbean groups and other Black groups far more likely to die of COVID-19. And we're seeing this in the north of England compared to the south of England. So my last slide, really, we need to think, what are the solutions here and what are these cracks? We hear this slogan, build back better. We hear it's a challenge. It's more of it's an opportunity and a challenge. But we need to go back a lot further than 12 months ago, before COVID-19. These big cracks in our society are gaping wide, and a little bit of cement going in after COVID-19, they will just open up again the next time we have a natural disaster and we have climate change coming, which we've heard about in this meeting, this tidal wave coming in the background. We need to really take this, to take many things into consideration to try to build back a more resilient, and that's such an important word in this, caring, compassionate society based on equity and social justice for all. And I'm not saying it's easy, but maybe what we've heard today up in the north, up in North America. And I'm very pleased to say myself, President-elect Biden will hopefully help a little bit more with this than ex-President Donald Trump. Thank you very much.
Thank you very much. And it was a presentation that really hit home with me. I was really wondering if you're really a virologist or a public health specialist, because the content of your presentation really hit home. You know, viruses don't discriminate, so neither should we. We need to learn from our experience, and historical experience is going to show us what we can really prepare for. And I really like the question, do we really care? And I would even frame it a little different. Do our policymakers really care? Because there are so many examples that our policymakers have the opportunity to do things differently, but are not. So this was really a presentation that reached home for me personally, and I'm sure all the other participants feel the same way. Thank you, and we're going to have some questions a little later on. It's my pleasure now to introduce our third presenter, Dr. Lisa Indar. She is the Director of Surveillance Disease Prevention and Control Division at the Caribbean Public Health Agency, CARPHA. She's an innovative public health scientist specializing in infectious diseases, travelers' health, and food safety. She has 18 years regional and international experience in managing and executing regional public health surveillance and response programs. With robust leadership, multidisciplinary technical expertise, she is health diplomacy, communication, capacity building, resource mobilization. Wow. She has a PhD and an MSc and a Bachelor of Science. She's the Director of Surveillance, Disease Prevention and Control Division at CARPHA, as I said. Responsible for directing, coordinating, and managing public health surveillance and response activities related to conditions of regional and international importance. She's currently the technical lead for CARPHA's comprehensive, multifaceted regional health response to the COVID pandemic, working with CARICOM, heads of government agencies, international, regional, and national surveillance, multi-sectoral stakeholders to keep the Caribbean safe and protect safe economic recovery. She also leads the Regional Tourism and Health, an innovative program that is addressing the health, safety, and environmental sanitation threats to tourism, with the aim of strengthening regional and national health systems to enhance the health of visitors and locals, and thereby promote sustainable tourism and economic resilience. Recently, under Dr. Indra's guidance, regional guidelines for resuming travel to the Caribbean and a comprehensive packet of proactive COVID-19 tourism measures to build assurance among the travelers that the Caribbean is healthier, safer choice as travel resumes were developed. All right, so it's a pleasure then to pass over the microphone to Dr. Indra. Welcome.
Hi, good afternoon, everyone. Pleasure to be here with you. Permit me to share my screen. Can you confirm you are seeing my first slide?
Yes, we are.
Okay, great. So this afternoon, it's my pleasure to be here. You would have been privileged to hear about CARPHA's overall response from our director. I want to take this into a bit of a different slant, where I want to focus on some of the innovations we have been doing with our Travelers Health Program as we respond to COVID. So Dr. St. John would have spoken about our overall regional response, and this slide summarizes a lot of what we do in terms of, at the highest level, because we are leading the regional health response for the Caribbean in accordance with our IGA mandate from our heads of government. So we would work, at the highest level, we'd work at regional coordination level. We work in terms of coordinating the different sectors. Epidemiological surveillance is a big part of what we do. Laboratory testing and verification. As we have produced a suite of technical guidelines, over 52 to date. We do a lot of capacity building. Dr. St. John would have spoke about the different types of capacity building we have done. In particular, which I'm going to focus on today, is our COVID-19 Tourism Task Force activities and our apps and travel health stamp. Otherwise, we do a lot of press communications, resource mobilization, and procurement for supplies and vaccines, as well as operational research. And I wanted to draw your attention, we do at the highest level, we have been instrumental or the technical lead in developing the documents for the travel bubble, the common health and border policy, the regional COVID-19 protocol for easing of the pandemic measures for travel by air and sea, the health sector country response guidelines for COVID-19 and influenza, repatriation of citizens, intra-regional travel, and so on. And online, you would see our regional, on our website, our regional COVID-19 public health considerations for reopening of borders and resuming travel in the CARICOM region. So moving gears now, I want to talk about one of CAFA's innovative program. Dr. St. John would have mentioned this program. It's one of our newest programs, started a couple of years ago, about 4 years ago. But this program is a bit different in that it is multi-sectoral. It involves the tourism sector, and it involves developing tools, health tools to address health issues in the tourism sector. And it involves not just surveillance, but surveillance, response, standards, policy, and training. So it's a comprehensive program, first of its kind in the world, and the tools are innovative. So we're really setting an international precedent in tourism health and safety. And we are not just aiming to enhance the visitors' local health and safety, but by extension, we are building travelers' confidence to come back to the region to say, you know, what we are doing is promoting healthy and safer tourism. And by extension, that would help in terms of economic recovery and tourism resilience. So the program addresses our tourism health, safety, and environmental threats through novel web-based early warning and response system, training, operational health, safety, and environmental standards, partnerships, the Travelers Health Assurance app, and Stamp, which was only launched yesterday. So these are the innovative tools, and it really speaks of CAFA's leadership and how we have been able to address this issue and the fact that we are the most tourism dependent region. And, you know, we cannot ignore the fact that, you know, more people actually come than those who live here. And most of our surveillance is on local infections. So the data we report all the time is just based on local infection. And so we are missing that major gap that, you know, what about imported illness? What about visitor-based surveillance? And we all know the first case of SARS, of Zika, and now COVID-19, you know, all came through importation through, you know, a traveler. So it made all the sense in the world for CAFA to start a travelers health program that looked at the health, safety, and the environmental challenges that impacted on tourism, and to come up with innovative tools, not just surveillance tools, but policy and partnerships and standards and so on, to be able to combat this issue in a holistic, multifaceted manner. And in doing so, we would, you know, improve the regional product of the region. We will enhance safety, regional health security from the health side, which is the key aim of health, and of course, tourism resilience. So the first of that product is this early warning and response travelers health system, which we call the THIS system. The beauty about this system, it is web-based and it's real-time, and it's available on your phone. The other beauty about it is confidential. So hotels and anyone who wants to report, you know, they are given a confidential password, they can report. The system is built as such, no matter what you report, you know, you do not need to be a doctor to report. It's based on symptomology. So you can report, you know, when someone is sick, they have everything. but the system analyzes, what you report and categorizes it into the different syndromes, the WHO 6 syndromes of gastro and acute respiratory infections and so on. And then it tallies that. And if you have passed a threshold based on the population of your accommodation setting, it actually sends an alert. So for instance, gastroenteritis, the international alert is 2%. So if 2% of your staff or your travelers is, if 2% has gastroenteritis, you will send an alert. That alert goes to the hotelier in a confidential manner, and it goes to the national epidemiologist and chief medical officer of the country. So it is meant to trigger a rapid response. So if this works well, you would not see large numbers of gastro or norovirus or COVID case occurring. You would not see the spread because you are nipping the illness in the bud. And we have countless examples of how this has happened for hotels and tourism establishments that are using the system. So presently we have about 13 countries using it, almost 400 tourism facilities. And of course, now as we are launching this Caribbean Travelers Health Stamp, more and more countries are getting involved. But the key is, and how we want to move with this, is to make this a part of our overall surveillance. So communicable disease surveillance is not just about local infection, but it also is about your imported or your visitor-based infection. So one of the steps is to move towards strengthening health systems in terms of integrating visitor-based surveillance and real-time visitor-based surveillance with this system. Together with that, and to support that, we have come up with 2 sets of guidelines that are published, regional guidelines for response to travelers' illness, whether you're in accommodation settings, that in the hotels and guest houses and Airbnb, or you're in the ship setting. Now, what is different? These guidelines are based on all the WHO and the ISO standards and so on. But what is important about these guidelines? It is instructive, harmonized, and standardized disease outbreaks. And that is because where we sit here at CARFA, when there's an outbreak, for instance, when there was the scare of Ebola or H1N1, and just recently, when COVID started around March, you have these ships that are coming in, and countries have no idea what is the standard response, or they have different or varied responses. The same occurs when you have an outbreak in a hotel. So what these guidelines are meant to do, they are in log frames, they're instructional, very easy to use, but they're meant to really provide what is the science response, and so you can harmonize it across the different countries. You need that harmonized response because if a ship is moving, it will move to 3 or 4 countries within a week. If persons are traveling, a person can easily, island hop within a week. So disease can spread. Diseases knows no boundaries. You need a harmonized response so that we protect the region. The third component is having an integrated system. So in addition to capturing the data from the guest houses and the accommodations through the TIS, we are also capturing data from from the Maritime Declaration of Health forms from the cruise ships. We are capturing data from laboratories, our environmental department, and a key part of all this is a CAFNet network, which is the Caribbean Travelers Health Network. So presently, we have working relationships with Travelers Health Branch and CDC, the Center for the Cruise Line International Agencies, the Vessel Sanitation Program, the Public Health Agency of Canada, Public Health Agency of England, and so on. And they all have Travelers Health Department. We work very closely and we share information so that we can really trace, because we all know when someone gets sick, the most times they go back to their country and they want to sue the country, or we get a negative reputation. So by working through, we are able to work, with countries and with our international bodies for that seamless surveillance, seamless response, avoid negative travel advisories, and to really let the world see us for what we are doing. Now, Another important component is capacity building and certification. This is perhaps one of our biggest component, because what we have realized in many of our outbreaks is that, is knowledge and information. So while we teach our environmental health officers and our surveillance officers, what is proper food safety practice or proper outbreak investigations, and what causes this bug to grow and what practices and so on, we realize at this hospitality sector, they're not aware. They're not aware they need to, for instance, they need to cook an egg until it's hard to the touch, that, pooling of eggs is an issue. They're not aware that norovirus, can be easily spread from person to person, and you need to deep clean and sanitize to get rid of it. They're not aware that, nails can transfer staphylococcus. So our training is a little bit different. It's an evidence-based training. We do a lot of training where we do train-the-trainer programs with the environmental health officers for the hotel sectors. And then recently for COVID, we have started the COVID-19 health guidelines for reopening. These are certified training. Part of having, of ensuring health and safety is to ensure proper standards of operations. So 3 years ago, we started the development of hospitality, health, safety, and environmental standards. These are Caribbean-wide green safety standards. They would have gone through the process now. They meet ISO standards, the Federal Tour Operator standards. We have gone through the health and safety and environmental standards from countries. We've worked with all the Bureau of Standards from our countries, our CAFA member countries. And the standards have now been drafted. They have been going through the process, through the CROSQ, which is our regional body for standards and quality. And because of COVID, these standards haven't gone through the process of ratification, but we hope that they are ratified and they become CARICOM standards. With these standards, operational standards, their checklist that, a hospitality sector, whether you're Airbnb or a big hotel, they can be able to be guided from the time a visitor arrives till a visitor leaves in terms of what are the safe measures. Multi-sectoral partnerships. For us to work and to do this well, we need to work with our tourism sector. Here is a health agency leading this initiative in a very innovative fashion, but we're really doing it for the implementators are really the tourism sector, whether it be the hotels, the guest houses, the cruise ships, the taxi operators, the destination tour operators. They have to lead it. So the first thing we did when we started was to really create an MOU with this Caribbean Hotel Association and the CTO. And then we expanded that, to the cruise lines and other agencies. And of course, while we were doing all that, we realized that, we needed to have policy. So in 2018, we would have presented this document we would have developed a document for regional policy for reporting of illness and what is the framework. Then in 2019, this was presented to the Council of Health Ministers and it was approved, meaning that, illnesses should be reported to the national authorities and using, the real-time information system. And then in early 2020, earlier this year, we would have then presented this to the COTED, the Council of Trade and Economic Development, and they would have also approved that. So we have an approved policy, regional policy for reporting of illness from the hospitality sector to national authorities. And to incentivize the hospitality sector, because we all know here it is, we are doing public health tools and we want the private sector to use them, to incentivize it. We started in earlier 2018 to start thinking about a traveler's health assurance app and a mobile stamp and a mobile app. When COVID came, it really pushed us and we had to realign what we are doing to ensure that the traveler's health assurance stamp will be modified to ensure it's providing a measurable and verifiable mechanism to ensure healthier, safer return to tourism. And at the same time, the app, which is a central depository for health advice, proactive health measures, alerts, health safety tourism destinations. But at the same time, the app tells you which is a healthier, safer destination to go. And that's globalization advocacy. So any traveler from anywhere in the world can be able to determine, which is the preferred option. So Dr. St. John would have shown this. I'm just showing it back to say all those measures, we would have then modified them and expanded them to respond to COVID. So in addition to those, we developed additional guidelines like COVID-19 health guidelines, guidelines for our travelers, our ships, food and beverage industry. We then expanded the TIS system, not just for the hotel and guest houses, but for the health centers, for transport, for tour operators, as well as self-reporting. The health assurance stamp was developed. We worked with CTO-CHT, the OECS, and the Global Tourism Resilience Center for Crisis Management. And we came up with the COVID Tourism Task Force that was launched in March. And as part of that task force, we do harmonized work and training. Every week we would put on our situation reports, weekly travel briefs and travel advisories and country reopening measures. I'll speak a little about the app. And if you go onto our website, you would see all of this. So this is the information system, and it's all that we are doing, we have adapted, for digitalized and virtual settings. So everything can be done, easy to use instructions via video instructions. And we still promote, again, the use of testing, testing that is greater than 90 to 95% specificity, the PCR as a gold standard. And of course, we are advocating together with that increased screening regimes and social distancing, mask, hand hygiene, and so on for the travelers. These are the COVID-19 health guidelines for reopening sector. Today, we have trained almost 4,000 persons. And these are the proactive health measures for reopening tourism. It means that a tourism sector should be using the real-time information system, and use mean they have to report. If they're not using it and not reporting, they would not get a stamp. The COVID-19 health guidelines training, and these two requirements is the first step to getting the stamp. The traveler's health assurance stamp, you would be given the stamp if you have gone through the certified training and if you're using the system. Later on, we will move through the tier system where we will increase the level of recognition of the stamp if you're using the guidelines and if you are using the operational standards. So this is a stamp. It was launched yesterday. The little icon that you're seeing on top is really the stamp, which is a traveler's health assurance, and it's unlike any other stamp that is being shown worldwide because it's the only stamp that is measurable and verifiable. So it takes a lot for us to do that measuring and verifying, but we want to tell our travelers, look, you have the confidence to come to our region. We want to tell the world that CAFA is promoting a healthier, safer option. And this is the app. And you see the different tiles there, it tells you about CAFA. The app is very unlike, again, any other app because it's not just an app about information that takes you directly to our website. It tells you what are the prevention measures. On the blue tile, you can go on and see what are the border measures, for any country. So you can go, let's say Antigua and Barbuda will tell you what are the entry requirements, what are the vaccination requirements, what are the testing requirements, and you links directly to their website. On the green tile, you would see the hotels or any tourism establishments that have now the stamp. We so far have a few. On the pink tile, it tells you all about a destination. It lists all the hotels plus the ones that are using TIS. It tells you what are the health centers, vaccination requirements, and other things about the country. On the red tile, it tells you alerts. So right now, in addition to COVID, we have dengue alerts. You would see that. And on the purple tile, you can link directly into our TIS system and report. So you don't have to go on. Once you have your login, you can go and report. So we are really enhancing security, regional health security, and promoting travelers' health. You know, you use the proactive measures that are measurable, you get the stamp, and then you are promoted globally, free marketing, but it tells you to come to the Caribbean. This is your healthier, safer option for coming to the Caribbean. And I want to leave you with this slide, which really speaks about our innovative partnerships. We are not just partnering with health. Yesterday, when we launched, it could tell these are some of our key persons who spoke. We had Minister of Tourism Jamaica, Minister of Tourism Trinidad, the CMO of Trinidad, the IDB. We had SCARFA, CTO, CHTA, Global Tourism Resilience Force. And then we had our stakeholders like the CEO of Sandals endorsing this and encourage every tourism establishment to use it. And the manager of Hilton. And of course, West Indies Cricket Board endorsed this, and we would have had videos, and those videos are going around now about the West Indies Cricket Board endorsing this for safer return to sports tourism. Thank you very much for your time.
And thank you very much, Dr. Indra. That was very informative. It's timely when you think of this being launched yesterday. And I'm sure that as we move forward in the Caribbean, the work of CAFA is going to be playing a major role in us getting back to some level of normalcy, even though we're not sure what normal would mean in the future. But again, it was a pleasure listening to you and getting that information. And again, at the end of the next presentation, we'll have some questions because I've seen a few on the chat. So if you look on the chat, you can start preparing for some of the questions that were sent to you. All right, our fourth and final presentation in this session is going to be Professor Rosanna Mart. She is from South Africa. She was born in this District 6, which they call the Old Slave Quarter of Cape Town, South Africa. In 1973, along with her family and hundreds of thousands of people, they were forcibly removed due to the apartheid government's Forced Removal Act. Her family were relocated to Lavender Hill, whilst others were relocated to the overpopulated Cape Flats. Rosanna Mart attended the Steerberg High School and was an active student in her young days, and at the age of 24, Woman of the Year award in South Africa for her work in the area of gender-based violence and for standing with four women, starting with four women, the first Black feminist organization in South Africa, Women Against Repression. She took her undergraduate education at the University of Western Cape, her master's at the University of York in the UK, and her PhD at the Centre for Contemporary Cultural Studies at the University of Birmingham, UK. Her work examines the intersections between and among political philosophy, Black consciousness, Derridean deconstruction, and psychoanalysis, all of which addresses questions of race, gender, and identity. Her first job was at Groote Schuur Hospital during her doctoral years at the Center for Contemporary Cultural Studies. She was a regular attendee at the Center for Freudian Analysis and Research in London. Professor Mart also writes fiction and is the winner of the Journey Prize, Best Short Fiction in Canada 1992. Her fiction books have made the African Studies Association shortlist for the Aidu Sydney Seidner Book Prize in honor of Ama-Ato Aidu in 2010. The homebrew list in South Africa is 2006 and the bestseller list in Canada in 2005. Professor Mart has served on the scientific committee of the first South-South philosophy textbook titled Philosophy Manual, A South-South Perspective, which was a UNESCO project and represents Africa, South and Central America, the Arab region, and Asia. She's a member of the Caribbean Philosophy Association, having completed a 5-year term as Black Consciousness and Psychoanalysis Secretary. Philosophy Born of Struggle and the International Assembly of Women in Psychology from UNESCO. Professor Mart has published several books, journals, articles, and book chapters. She wrote the race chapter for South Africa's first sociology textbook. She has supervised students in fine arts, sociology, philosophy, English, politics, international relations, law, and gender studies. She has open exhibitions for a number of artists across the globe. And in 2016, she received the William Jones Lifetime Achievement Award from Philosophy Born of Struggle for her work in philosophy, especially her groundbreaking work in Philosophy Born of Massacres. In 2017, Professor Mott won an award for research excellence from UKZN and an award for Student Mentorship Award. In January 2019, Professor Mott was appointed as an International Research Ambassador to the University of Bremen in Germany. So it's my pleasure to welcome Professor Rosina Mott.
Hello, everybody. Thanks for the invitation. I'm always embarrassed hearing my bio. I'm so glad somebody else writes these things and not me. But thank you for the invitation. I hope you can all hear me. I know that I have 10 minutes, but I did want to just thank the organizers and everybody involved in making this possible. This pandemic has left many of us working on our own, pardon me. And sometimes when we have the opportunity to work together across the globe, it makes our work so much more meaningful and so much more important. So thank you for the invitation. I'm going to try and stick to my 10 minutes as much as I can. So I just want to start by saying I'm speaking from a manuscript. Well, I'm not using my manuscript to speak, but the title that I use here in conjunction with the title that for the subdivision of this panel I've used is called The Virus and the Crisis, Racism, Performance and Pavement Politics. It's from a forthcoming Routledge book. Could I please have the next slide? Thank you. So I'm going to try and just look at 5 main points: the virus, the crisis, bodies in transit, social spaces and colonial cases, racial tropes and scopes. Please, the next slide. So I just want to give you a little bit of background in what I do. So my PhD is in political philosophy and psychoanalysis. I've run several research groups at the university. Some of them, like Race, Space and the City, looks at the relationship that race to conditions under which people live. Then also Critical Times, Critical Race, very similar. The Race, Space and the City is with engineers and architects and people in the built environment. And Critical Times, Critical Race is a lot more broad. Most of my analysis, I would say, which I'll come to a little bit later on, is informed by Steve Biko. My first job was in a hospital. I worked in emergency unit and gynecology as a social worker / therapist. As a young child growing up in District 6 and then forcibly removed to Lavendale, I was 11 and a half. I broke out with hives every year on the same day, which is the 4th of August, which I've now transitioned to Obama's birthday. That's what you learn in psychoanalysis. Any event that's painful or difficult, you try to transition it to something else. And so I grew up sort of going in and out of hospital the following day. But one of the things that really drew me as a teenager at the age of about 12, 13 was being at school and knowing that Steve Biko was banned in South Africa, but Frantz Fanon wasn't. So I was able to read Fanon with my friends, but we're not legally allowed to read Biko. And I read a small pamphlet that completely changed my mind. That pamphlet was important enough for me to understand why people like Steve Biko, Frantz Fanon, and Che Guevara studied as medical doctors. And I say this here, especially in this talk and this conference, because I have a great appreciation for people who work in the medical field. I don't. I started off in a hospital. I worked there for about 3 years because it is precisely people like Steve Biko who made me understand the relationship between health and the material conditions under which we live. And in the context of South Africa, it is important to note that not only did Fanon experience that in Algeria and France, and Che Guevara understood that in Argentina and Cuba and other places in Africa that he visited, which made these revolutionaries even much more important to me as somebody who's a social scientist whose study tries to incorporate psychoanalysis into what I do. And that is to look at that relationship. How do the material conditions under which we live, especially the racialized conditions of materiality, determine our relationship to our health and welfare? So when the coronavirus, later known as COVID-19, hit the shores of South Africa, this was on the 5th of March in this year. We have, as you may or may not know, quite a big European population, some of whom are East Africans, that's what they call themselves, who had returned from South Africa, and 5 days later they were basically diagnosed with having COVID-19. Immediately, Cyril Ramaphosa, our president, took action to try to address the situation head on. They were put in quarantine and were asked to give a list of people they had been in contact with. And those people were sought after as well. A few days later, he made quite a big gesture and asked basically assisted 114 South Africans who had not tested positive at all to then be able to repatriate from Wuhan, China, back to South Africa. Our lockdown happened a few days later. The university lockdown was imposed on March 16th. The nationwide lockdown was implemented around between the 25th and the 27th, but it was very quick and very swift. And I will come to why this is important later on. So one of the questions I asked in the beginning, as I was still talking to research students, is what is made known of the virus and what measures are being put in place to safeguard the health and welfare of South Africans? Now, I think in any given situation, a president can do all of what it is supposed to. And I think Ramaphosa was praised internationally for taking action very swiftly. Next slide, please. So I talk about the crisis and the virus. And when I ask what kind of measures can be put in place, I'm also then at this stage of my manuscript and research work answering the question as much as I can. And basically what we saw was the fact that European South Africans, or people who were either South Africans or Europeans living outside, had forcibly basically maneuvered themselves into the country, paying people at the airports, bribing people, also flying to Lesotho and Botswana, where they also basically assumed that there would be less of difficulty getting into the country, and then driving into South Africa because they knew that the airports were secured and there was heavy security and testing, and people being asked quite intense questions. Now, in my book on this particular topic, the crisis and the virus, obviously the decision to call it that came after all of the protests that happened in the United States and worldwide. And I evoke people like W.E.B. Du Bois, precisely because he started a journal called The Crisis in 1910. Now, as I'm sure some W.E.B. Du Bois also studied in Germany, and many credit Freud for ideas that were in circulation at the time. And one of that is, for example, W.E.B. Du Bois is quite well known for his work on double consciousness. And what he says is, double consciousness is the consciousness where the Black man, and he uses man, sees himself, but also sees himself being seen. And what I found very useful in doing this kind of work in this area as part of my research was also to understand why people like W.E.B. Du Bois had to start a journal like this, because he saw the crisis as being the way that people were racialized in the United States. And he saw it in 1910 as quite a severe crisis. Now, between 1898 and 1910, so from 1898 onwards, W.E.B. Du Bois is influenced clearly by philosophy and psychoanalysis, and writes about double consciousness because he's concerned with the impact that white European gaze the gaze of the colonizer, the gaze of the European, who then basically strips the Black man, and again, I'm using the phrase, of an identity, and the Black man is forced, has to come face to face, is in crisis because doesn't see how he could be seen in this way. And of course, we see this happen to Frantz Fanon in metropolitan France, in Paris, when a similar situation happens to him. So my question here is also not just about what is a crisis and what is the virus, but it is also about looking at the way, for example, that Albert Camus in Algeria wrote in 1947 and used information of the 1880s plague. But interestingly enough, Camus' book called The Plague really was really way ahead of his time, but also looked at the relationship that the power shift started to have within that society, in a society that was stratified along race and class lines. So The Plague for Camus as a novel was not just about saying, let me write about how physical and mental illness start to affect people when there is a plague in the city, but he also then used that as an opportunity as the plague unfolds to look at power relations. And that is what I think I saw certainly internationally, and I saw in South Africa. Next slide, please. So yes, this is Albert Camus, and also the plague is particularly known for its depiction of existentialism. And I think when we talk about existentialism, it is not only about how we live in the world as the human subject, a subject without being racialized. And I know that for many of us, that's not an option. But existentialism is really about how we exist in the world. We know at this stage of our lives, most of us anyway, that we are racialized subjects, irrespective of where we go and where we live and how we move around. So next slide, please. So this is, pardon me, so I want to talk just a little bit about the influences in my work and this particular area of my work. I want to take you to Karl Jaspers, born in about 1883. Studied philosophy and so became a medical doctor. And what Jaspers did, and this is why we see Steve Biko refer to Jaspers. I think Fanon refers to Jaspers, Che Guevara refers to Jaspers as well. Jaspers was one of the first people who basically made sure that in a hospital, patients, the biographical information was taken. So now when we go to hospitals and they say, we need this information about a patient before Jaspers's time, before Jaspers implemented this particular system, it did not exist, because Jaspers, not only did he stand up against the Nazis because his wife was Jewish and left Germany, he understood very much how that relationship between the material conditions under which we live and our physical health and our mental health, how that was being determined. And so in terms of my work, some of the influences that I'd like to bring to your attention. What is the relationship then between critical race theory and revolutionaries like Biko and Fanon? Biko didn't finish his medical degree. Che Guevara stopped, did the bicycle diaries, returned to his medical degree, and then finished. Of course, Steve Biko was kicked out of medical school for, I'm sure, reasons that you all know. But it was very, very much the sense of, in his work, you see this, the kind of borrowing from people like Fanon and Guevara and others who had studied medicine and also psychoanalysis. Next slide, please. So, so in this particular chapter, which I'll talk about very briefly, I examine the features that mark global travel in the early months of the coronavirus, its defined status as a pandemic, the bodies in trends that are racialized through various performative practices, and the refusal by Europeans to see themselves as carriers of disease and infection as they bribe the colonized masses of various African countries for entry despite regulations in order to carry out their seasonal trips of sexual tourism and sightseeing missions. So not only were South Africans not allowed to leave the country, we were not allowed to leave our provinces, we were not allowed, the lockdown was very specific. We still had Europeans coming in and still driving to close by countries, bribing, refusing to leave. And I want to just please go to the next slide so I can further elaborate on this. So this is what would happen. We would have Europeans come to Lesotho, Botswana, Malawi, change their, not understand that, you know, there would be measures in place, arrested, and just absolutely refused to give information because, of course, 90% of South Africa's population is Black, and there's just no sort of sense of regard for somebody who's an official, because this is a regular scene. You know, I call this the scene of the crime each time, because it is a complete disregard for any sense of law, any sense of authority, lying, going to hospitals, and then also having been tested positive, but still going around the country. And that is because, in my view, the European mindset is unaccustomed to being treated as a carrier of a virus or a disease or an illness. And there's also the other sense of just, you know, oh, well, South Africans, you know, they live with HIV and AIDS. They can withstand anything, you know, they're tough. And, you know, we the Europeans, it's total disregard for Black bodies. Next slide, please. So this is called Chinsa. It is 40 minutes outside of East London, which is a city on the eastern coast, quite close to Durban, where I live. I'm from the Cape, but I live in Durban. So Chinsa is outside of East London, which is 6 hours from Durban. And the African Phenomenology Conference was here. So people like Lewis Gordon, what's his name, Achille Mbembe, myself, and I forgot, Huntunji from Cote d'Ivoire. Several people were there, only to find out that the German folks who were there, you know, when we left, one of the workers had gone to a room and found this person wasn't breathing properly, called the authorities, and the whole place had to shut down. The whole place. Questions at the border. They were asked to be tested. You know, they refused to have their temperatures taken or anything. And of course, you have Black staff who are from the rural areas, who, you know, South Africa's only you know, 26 years into democracy after 342 years of usurpation and colonization. So there's still that sense in which we have Black people working in strategic places like hotels and the tourist industry who were just absolutely flabbergasted by the refusal of Europeans to actually comply with regulations. And so what happened, this whole place had to shut down. We were contacted, none of us tested positive at all. But this is exactly what the interest is to go to African countries, you know, to be the ugly tourist, to make a kingdom, not see yourself as a carrier of a virus or a disease, and have absolutely no regard for regulations or the law. Next slide, please. So in this particular chapter, I talk about a few cases such as George Floyd, the murder, the protest that ensued in the United States. It spread across the globe, which I also found interesting in the UK and several European countries. The target for protesters was to remove statues of that embodies enslavement. So statues of either slave owners or you know, considered figures in particular European histories. So these were images that were removed. And I'm sure all of you know, or may not know actually, that we had Rhodes Must Fall here, which started in 2015, student fought for the removal of a huge image of Cecil John Rhodes at the university. And this is partly because they felt that physically having the statue was having such an impact on their mental health, that we have the right, if you say, you know, you are a free society, we have a democracy, we have the right to have social spaces that do not remind us of coloniality. We have the right to have social spaces that do not say to us, you know, I'm still in charge. You know, I built this university on slave labor, which is actually my forefathers' labors and my foreparents' labors. And what I found interesting about this particular period, just after, during the George Floyd and other protests internationally, was just the fact that, so I have quite a bit of contact with Germany. Being an international research ambassador does not prohibit me from speaking out. I wouldn't be the kind of person I am today if I thought that silence was a nice ticket to get a university professorship, because it isn't. It is this sort of way in which I began to look at organizations, scholarly organizations, actually saying to protesters, we don't mind if you protest, we just mind that you're violent. You know, can you not do these protests with violence, because, you know, you're going on the street, you're spreading the coronavirus, and this is detrimental. And then, of course, one reminds them of the violence that they did in Namibia between 1901 and 1906, when they killed millions of Nama and Herero people as a starting point for what they later did to Jewish people in Europe. Yes, so these are the inaccuracies of what we understand from European history: a kill, murder, maim, and massacre, and then turn around and then tell Black people, you know, don't be violent. Next slide, please. So, sorry, I'm trying to move this because, okay. All right, so there were protests in South Africa in a similar vein, and a lot of us felt that, you know, the Europeans who were coming into the country were not properly dealt with, and this is because I think our president and our Minister of Health were trying to basically say, we want to do this with the best form of dignity that we can. And at the same time, we know that children around the world saw what happened to George Floyd, and it's not just about one person, but it's the indignities that are forcefully implemented and forcefully enacted on and bodies in an absolute disregard for the fact that the virus is actually racism. And this particular spread of racist violence we saw everywhere. And I want to go to one more slide and then I'll sum up. Next slide, please. So I'm talking particularly about the characterization of the Karens, or Karens, as you say in the United States or North America. I've written about something very similar in South Africa. Every single year from about this time on, so from November till January, we will have the usual outpour of racist slurs, usually from white women, talking about Black people on beaches, and the Simeonization, calling Black people monkeys, all kinds of things. So we have that in South Africa. Oh, Black people spread disease. There's so many of them on the beaches. So this kind of characterization as a Black and African subject as a diseased subject is not new. A Black and African subject, not only as a diseased subject, but also as a monkey or an ape. So this Simeonization is something that is global. It is not just in South Africa. And it's certainly, we've seen all the amount of King Kongs that Hollywood has produced, usually during depressions or in the period when the morale of the nation is low. So when the morale is low, just use a Black man to basically uplift yourself, because then you can see what animality really is about. So I play on the word here, racial tropes and scopes. There were a lot of TikTok events here, which I didn't actually know about because I don't do that, but I didn't even know such a thing existed. So we saw a lot of that play itself out during the virus and during the period of protest. And I specifically look at the whole carry a scenario, the way in which she understood what it meant to wear a mask, what it meant to kind of raise her voice, what it meant to call, to perform an act of racialization on a telephone, and use her voice, use the history of the knowledge of what does it mean to put Black men down constantly, and to just say, I'm being threatened. And I use the word on scope, because I think it is important that in the medical profession, and just in all areas of our work, that we connect the social political arena, the analysis of what we see in terms of our social justice position, that we connect it to health, that we also understand that the psychological impediments that inform the way that racism is acted out, virus or where it isn't. This was exacerbated by the fact that people were masked. And that exacerbation is not something that happened, that came only because people were masked. I think the exacerbation was given a license because it is very easy to call the police on a Black person. So I think I want to go to my next slide, and I'm happy to take questions. I don't want to take up too much time. So in summation, in this particular presentation, I talk about the virus, its containment, and the ability to deal with it means to offer protection to citizens in South Africa, vulnerable communities. And then we see European communities of tourists overlook the impact that their presence have on Black people, the question of addressing the health and well-being of vulnerable communities, who inflicts the virus and who relies on the crisis. In other words, the material conditions under which we live with health and survival, and then also how race takes center stage in the world during the coronavirus period, at the height of the coronavirus period, and why, and how racial tropes flourish amid the period of caution, fear, and the threat of death. Thank you very much. I'm going to end there, and I really appreciate the time and efforts to be on this panel. Thanks a lot, everybody.
Thank you, Professor Mart. I sat here listening with intensity and really trying to grasp that linkage between the coronavirus and the way we treat our people, and with race taking center stage as one of the comments you made, I couldn't help but thinking about Vice President-elect Kamala Harris being a Black woman and taking center stage as part of the leadership of the US. It would be interesting to see how that is really addressed as we proceed. All right, so I really enjoyed this 4 presentations, and before I hand over to Dr. Bidesi to deal with the question and answer session, I want to take the prerogative of the moderator to start by asking Ahmed. Well, of course, from your first presentation, I was intrigued, and one of the things that came to mind over and over is, have you, in dealing with the policymakers, how easy or difficult was it for them to look at evidence-based decision-making rather than intuition and politics?
That's a great question.
So before we begin, guys, we also have a student who is joining us in this question and answer component, as we want to encourage our students to share this experience with us. So let me just introduce you to Nicolette Chiam, a first-year medical student at St. George's University, received a Bachelor's of Science in Biochemistry and Molecular Biology, as well as a Master's in Medical Health Sciences. She's very much actively involved in research, particularly working on infectious disease, especially mental health and physical health, among pediatric HIV patients in India and Tanzania. So we certainly welcome Nicolette to the discussion. And of course, Dr. Khalid, you can go ahead and begin your response to Mr. Roberts as we continue the question answer component to this panel. Thank you.
Thank you, and welcome. I love that question because actually it's a main concern of ours here, is that how well are we providing research evidence to inform decision-making and policy development? And the reality is, shortly put, what the policymakers wanted, especially here in Canada, is reliable, short, succinct, clear, jargon-free evidence. So As my role as a research manager for Evidence Aid, which is an organization that reviewed all the evidence that's generated around COVID-19, my job is actually to take very heavy and long systematic reviews and synthesize them into simple, explicit list of actions. So policymakers, really what they want from research evidence is that, can you tell me which intervention works best? And what is the quality of the evidence when it comes to implementing that intervention? Those two key components of evidence synthesis has been remarkable in transforming the way researchers in public health and in health systems research think about how they write their papers. We're seeing a much, much heavier emphasis on shorter papers that really help translate the evidence.
Yep. Okay, guys. So what I would like to do now also is just ensure that all of our questions and comments in our chat box are actually posed to our various panel discussion representatives, and was certainly quite a deep but also diverse contribution, ranging from migrant refugee health to human animal environmental interactions and the impacts of rural community settings, to travel and tourism, which is a critical aspect of economic sustainability for different regions, and of course the issue of racial inequity, systemic, and how that manifests in terms of past, present, and certainly future as well. The first question is, and I'm of the belief, to be honest with you, and I've always been, that structure determines function. You know, how you function depends on how you're structured, and these systemic inequities that exist historically, currently, are also, it's a symptom of a structure. If we are to meaningfully address the economic structure, the social structure, the education structure, the environmental structure, what are the fundamental reforms that we need to consider so that the structure can then function towards a more equitable, equivalent, just outcome for the populations, the societies that we are speaking about? I open that to all the panel, and maybe Nicolette, you can probably begin with your thoughts as a medical student, as someone who is actually on a path towards contributing as a healthcare provider in a system and a structure that tends to disproportionately affect persons that are underserved, that are on the lower socioeconomic level of society.
Thank you for the introduction, Dr. Bayashi. In my opinion, I think the basis for foundations for any change is to be able to have uncomfortable discussions about, social inequities or any other underlying problems within any foundations for these inequities. And for that, I think that if we're able to encourage these realms of communications in order to start these conversations, then not only are we able to, bring more recognitions to them, but also make it less uncomfortable, where we can have more collaborations where people from various groups can come together to resolve the issue together.
I agree with you. Being uncomfortable is not a bad thing. And sometimes it's about disorienting ourselves and allowing that disorientation to formulate a constructive orientation as well. Yeah, certainly. Other panel colleagues?
Hi. Yeah, that's a very big question, Satish. It's what we're all grasping at. And I think, so part of the issue here is knowing how to communicate with different groups of people properly. And we've seen this emphasized, I think, a lot with the climate change debate, because, we have the vast array of people with different beliefs. And it's how we get the message across, but get the message across in the right way. And how this is being done in many cases is to emphasize the co-benefits and the positives. You know, when we look at sort of coal-fired fuel powered stations and air pollution, and you know the co-benefits of cleaning up the air, and you know, I mean there are also co-benefits. What I was talking about was, you know, even if you don't care about people dying in certain parts of the world of viruses because you're greedy and you're not compassionate, you're not compassionate and you're not caring, even if you don't care that people are dying of Ebola or people's livelihoods are being ruined by African swine fever virus, you can still get the message across that if you do actually work on those viruses at source in the country, you can not only stop them where they are, do something about it, but you also avoid all the money and all the heartache and all the deaths. You avoid those viruses coming to the Western world, coming to your shores. So you're focusing, you know, because we're not going to stop that. We have different people with different beliefs. You know, we believe certain things and other people are at completely the other end, and we're not going to change their views. But we have to think very carefully about how we sort of communicate and manipulate what we say so they feel it's important for them. And I think that's what we don't do very well. I mean, apart from all the other things, that's what we need to learn how to do better, is emphasize there's always positives for everybody, but we need to learn how to direct our communication better.
Sometimes the more forms we have to communicate, the less effective we are at times, which I think sometimes is another struggle as well. And yeah, that's important. But communication is fundamental to understanding, and understanding leads to the knowledge and the perception and the attitudes that eventually determines behavior. So fundamentally, communication is critical. Sure. Any other comments on the structural and functional considerations as it relates to how we manage these inequities? Well, it is probably a priority for us and collectively, and certainly in all that we do. When we think about health for all, we think about in terms of the economy, we think about in terms of education, we think about in terms of the work environment and the natural environment as well, and that's an aspect for us to certainly always include towards assuring that type of equity that we're all yearning for, essentially, especially at this particular point in time.
Yeah, and Satish, if I may add, you know, the all of society approach, we all say, yes, we're engaging in the all of society approach, but it's really putting that into action. And this is where I think, you know, persons like us and these types of meeting can help, because all of society approach and equity for all means that whatever structure that you do to put systems in place should consider all of society. And it's sad to say, even, you know, access to health and access to services, it's not always, you know, equitable. So, you know, part of what we do has to be, you know, make things to make things equitable, but also has to be easily accessible for all of society.
Another point, you know, sometimes we think about it's available, but is it accessible?
Exactly.
And there's a fundamental distinction between the two.
Mm-hmm.
You can have education that's available, but it's not equitable.
Mm-hmm.
And those are three particular questions. Whatever service, whatever provision you're making, accessibility is just one component. Availability is another component, and of course, equity as well.
Yep.
I think also money talks, of course. And you know, we see this in research. I mean, the money is directed in research to certain areas. And you know, we've talked about, you know, the multidisciplinary or intersectoral type One Health-based research.
Mm-hmm.
And if you can persuade the people giving the money to direct that kind of that funding towards a certain type of research, and I'm thinking about this could be taken broadly towards, you know, structural reform and things like that. if you can persuade the money to be directed in the right places, then people will make strides to improve the situation. I think often the money is maybe not directed to the right places in some cases, and so we don't make the most of it.
Dr. Khalid, I have a question in the chat, and it's related to the issue of refugee migrant health. And the question is connected to different health systems. You have private health systems, you have socialized health systems, and how these different health systems mean different access, availability to especially migrant and refugee groups. Can you comment on the disproportionate realities for migrant refugee groups as it relates to the specific health system that they are interacting with?
Excellent question. So it really depends on where the refugees are being housed. So if we look at Jordan, for example, Zaatari camp being the largest refugee camp in the world, or at least for now, one of the largest ones in the world, we see that the dependence is on the UNHCR, which is the United Nations, the Human Rights Commissioner for Refugees, to provide healthcare services for those refugees. So they exist within health systems of the country, but it depends on what they have access to. In Lebanon, in contrast, the Syrian refugees very much heavily depend on the national healthcare system, which means there's a huge fatigue on the system to be resilient, to not only answer the health needs of their own citizens, but also this influx of refugees. So it all depends on the country and context. But what we're learning over time is that UHC, or universal health coverage, is going to be so exceptionally important in the coming future, as we know that the number of refugees is only on the rise, and then we're going to have more and more refugee camps around the world that will put a strain on health systems. So the idea of being able to provide universal health coverage to all people in that context is going to be exceptionally important.
Okay, Dr. Indar, we have a question in terms of this approach now towards increasing regional travel, all within the context of the certification and the stamp initiative that has been rolled out, recognizing that the Caribbean region includes different COVID-19 realities, probably even different tourism needs. How can this effort be seamlessly rolled out into a region where you have different type of health, economic, and tourism needs and expectations?
Right. That's a good question, Satish. And what we are doing, you have to keep advocating and promoting. And, you don't have to just do it, on the health sector. You have to do, that same all of society type of promotion. So yes, we have launched this, but we have launched this with our tourism partners. And the key people to drive this, the travel agents, the tourism associations, the ministries of health, not just the Ministry of Health, the ministries of tourism. So you need that harmonized approach to say, these are our minimum requirements, because we are dealing with, many countries. CAFA has 26 member states, small, and they all have varied requirements. But the thing is, we are so close together. Our borders are so close. We are so porous. We are so vulnerable. I mean, if we don't have minimum requirements, COVID will spread. So we have to come up with a minimum requirement. So it takes a lot of advocacy at the highest level, and we are doing that with our heads of government. It takes the advocacy across the sectors, health and tourism and ports of entry and everyone, in terms of what are the minimum requirements, because this is about protecting us and protecting, the health and well-being of our visitors, but also us, the locals. So it's a multifaceted approach, and that's the approach we are using, and we're going to give it our best shot. But there are countries that are going to vary, so we will keep advocating to say this should be the minimum requirements, because I'm sure you have seen in the news, sometimes one particular island may not be doing something, will be doing all the right things, but then you have visitors or travelers going unannounced, even sometimes through illegal immigration and so on, and then the numbers go up. So, but when the numbers go up, it's a virus, it's going to spread. And then what do we do? It's going to impact, you know, not just on our tourism economies, but on our livelihoods. So, you know, we have to take that multi-sectoral approach and advocate at all the different levels.
Thank you for that feedback as well. Very instructive. And Dr. Mart, we have many comments on particular questions related to your presentation as well, especially in terms of the whole aspect of how do we advocate for that level and necessity for equity across the racial divide going forward, using different strategies that have not necessarily proven effective. So we have unproven, ineffective strategies that have not yielded the type of equitable, sustainable outcomes that different social, racial, ethnic groups are seeking. Innovatively, creatively, maybe even technologically, what are some of the prospective tools that can be used to seek this yearning equity that many ethnic groups around the world are seeking? What are your thoughts on that?
Okay, thank you for the question. I can only see a small segment of the question, but yeah, I'm not sure how to go further up. But let me start by saying, and again, I'm not sure how many people know about the way that the apartheid system worked. So in a hospital, for example, you will have a section for Black patients and you will have a section for white patients. So after 94, universities, schools, hospitals had to find a way to what is called here to kind of transform its structure, right? So for example, that in itself, like let's just look at the hospital structure, that in itself was a very clear indication why people like Steve Biko started community health clinics, because of the Black population just did not have access, right? There were hospitals, but did not have access. So it is a question of not only having to transform, because here in South Africa, we have a transformation charter or document at all schools and all universities, right? To look at how we can transform our society. So, you know, if I'm sounding like I'm multi-pronged in this approach, it's because I believe it is precisely a multi-pronged approach that is going to move the process forward. On the one hand, you can have legislation, right? So our constitution, the first democratic constitution, was introduced shortly after 1994. We now have several amendments. So we now have a 1997 one that declares, you know, equal health for everybody. At the same time, you know, having said we can have all forms of laws, but part of the problem that South Africa has seen is that we can't legislate attitude. You know, are you with me? Yeah. You can legislate for and against anything, but you can't legislate attitude. So not only do we have to, the kind of work that we do in many different fields, whether it's physiotherapy, whether it's general medicine, whether it's psychoanalysis, whether it's health clinics, we actually have to transform the way that people see Black bodies. So for example, if you look at European newspapers and you see, beaches often, I mean, I collect these kinds of things online because it's one of my areas of research work. I mean, the indignity of showing hundreds of Black bodies on European beaches. These would be sort of Italy, Spain, on the African continent, going to Europe, right? On these small little boats, of course they capsize and of course they drown, and you have a morning newspaper filled with Black bodies, on these beaches. And again, I mean, that's one way of just making people aware that you would never show European bodies with that kind of indignity. So the kind of work that we have to do in all areas of what we do, whether it's in health or the social sciences or the arts, is that we have to constantly and critically examine what we teach, our curriculum? How do we transform the thinking of young people coming into a democracy, into a thinking that has to shift to what people like Lewis Gordon and Enrique Dussel and Mignolo talk about, shifting the geography of reason. In other words, having to produce knowledge that allow people to think of themselves outside of the framework of what the colonizer had suggested. I mean, I've been to Dakar, to Senegal, to other places on the African continent, and we're struggling with similar kinds of things. And that is to make it sure that we as educators in all the fields that we do our work, that we go out of our way to try and change the mindset. Because policy and legislation is one thing, but the mindset is very difficult to transform. And we have to place our energies there. I know this is a longer discussion, but I'm just going to say that for now.
Well, complicated problem requires complicated solutions, but I agree.
Yeah.
It all begins with the mind. And that's a good place to start. And it's the only place to start, I believe, you know, and that I think it's a good way for us to end, in a sense. Unfortunately, while I feel saddened by ending this particular panel, because of course there's a lot more we can talk about. I'm sure the conversation will continue along the way among ourselves, among our online community, among our colleagues, and of course around the world as well at the same time. So thank you to our panelists.
Thank you. Thanks.
Insightful and very provoking, and it has been very instructive, and that only augurs well for a learning experience that we can then translate into meaningful action, which is essential as professionals and as people at the same time.